Cool.
Actually, should I start my video? I might as well join you in showing. Cool. So welcome to the first of the Paediatrics revision sessions. Revision kind of being at the start of your placement, but anyway, um, I think there's a lot of info in these slides, and I think that we obviously can't go through everything, and we obviously can't go through everything in massive detail. Um, but all of that to say, like, don't feel overwhelmed. For most of you, this will be the start of your placements. Or if you've just finished, it will just be a way of seeing what the most important things were, just a reminder, you've seen the important things just one more time. And by the time exams come, you will have seen almost everything in this session you would have seen about a million times. So it's just about reminders of what's important, some important differences, or some key things to keep in mind when it's like a PEDS station or a PEDS question. Um, but yeah, all of that to say, don't feel too overwhelmed because there's a lot of stuff, but that's okay. Maria, do you want to say anything else, or are we good to go?
Yeah, I think a lot of people will join via the recording. So ho yeah, hopefully it'll be useful basically. Oh, actually we forgot to introduce ourselves too.
Yeah, sorry. I'm Giulia.
And I'm Maria, I'm one of the final year medical students too.
Yeah. And if it's any consolation, a lot of this stuff I was looking through and I did not know in that much detail, and I still did fine. And also, I never came to any of these lectures or knew these were happening, and I still did fine. So you're one step ahead of me. So, right. It would be useful. There we go. Oh, sorry. Let me go back. So we're going to cover history taking, developmental milestones, a lot of some of the key RESP things, viral rashes, fluids, jaundice, and BLS. You can see the things we're not covering, but a lot will be covered in part two. And actually, this is quite a good overall look at some of the key topics. So I think it's quite a good way to start. And so we'll start with history taking. Um, so a lot of PEDS history taking has some new steps or some different steps that you normally compared to your normal adult history. And sometimes it can feel like, is this question really relevant to what this person's come in with? And I think what we need to bear in mind right now is that we're not at the stage to make that decision. So really practice asking all of the questions, even if they don't seem relevant, because whereas someone more experienced can know that a question isn't relevant, we just need to cover all bases and be safe as always. So the first thing to do, especially in like OSCE stations and in real life, is confirm who is with the child. And if the child is of an age where they can speak, especially, but even if they're young, kind of acknowledge the child first. If they can speak, get them to introduce who they've brought in and just get them to take as much part in the process as possible, even starting by asking them about what's wrong, what they've come in with. And then you can be like, is it okay if I ask mum or dad or the person that they brought in some more information? Just I think it comes across nicer and it puts the child a bit more at ease. And then you've definitely got the usual presenting complaint, history of presenting complaint, do as much Socrates as you normally can. Um, you might not get all of it, but try and still be as thorough with the PEDS one as you can. And get time frame for everything, and always good to reflect back what they've told you or to clarify things. Be like, so they started vomiting on Saturday, and then on Sunday they got a temperature, things like that. And always remember to ice, but icing too early sometimes in exams can catch you out a bit because some um, of the examiners are told to like not tell you something straight away. So I think after presenting complaint, history presenting complaint is quite a good time to ice. And then if you have any doubts about maybe there was something else, you can always do it later again. Um, but just always important to remember that. And now systems review, there is a lot in it, but the most important things are they eating? Okay, that's fine, but are they drinking? Like if they are breastfed, you want to know that they're breastfed. Are they having formulas? Are they drinking as much as they normally do? Or are they refusing to drink at all? Are they vomiting? Are they having lots of diarrhea? You basically want to check if they're going to be really dehydrated. Um, and the same principle for asking about going to the toilet. You really want to ask about wet nappies, the last time they went to the toilet to do a pee, things like that. And then your general aspects, behavior change is a massive one. Parents will, or carers will always be like, they're not normally like this, and then they've just become really clingy, they've become lethargic, they don't want to do the things they normally do. So their activity levels is really important. And then just general, obviously, like fevers, change in weight. And then I'll let you read through the rest of the systems review. But again, even if it doesn't feel relevant, always good to do a top to toe assessment. If you're feeling short of time or you just want to practice going through it a bit quicker, um, even in like adult systems review, it can be useful to just be like, I now just want to ask you some quick yes, no questions just to do top to toe, make sure we're not missing anything. And then you can just list off your things, and for each thing they can be like yes, no, yes, no. And then you want to go into past medical history, which is where I've integrated the other things that are really important in PEDS history. So the usual of like, do they go see any doctor regularly? Do they have any conditions that do they have any conditions, generally health conditions, but do they see a doctor regularly? Who are they seeing regularly? Have they ever had to be admitted to hospital? Have they ever had any surgeries? And then you want to go back again. So then you want to go on to their birth. You want to ask how the pregnancy was, if there were any issues, how many weeks were they when they were born, and how much did they weigh, if they can remember that. How was the delivery? Were there any complications? Did they have to stay in hospital? Did they have to stay in the NICU? Just to give you some context for their general health and well-being. Then an important part of PEDS is growth. I would suggest at least once look at a growth chart and genuinely try and see like where you would plot things just in case. I don't know, but just in case it were to come up. But also I think just for understanding them when if they're ever given to you. Growth is really important. You want to make sure that someone hasn't fallen down a percentile. And that is something that you normally, like if they go to the GP and things, that they will always check that the child is growing well, and always ask if the parent has any concerns about it. Ask about immunizations. When you ask about them, be curious. If they say no, or they say they just haven't had the MMR or something like that, just, I think, approach it from a non-judgmental, kind of curious point of view, to just be like, may I ask if there's any reason for that? And then just explore that, because an important thing is that every interaction with a healthcare professional is an opportunity to promote them getting immunized if you can, but obviously everyone has their own opinions on that. And then you want to ask just a quick mention about like development. Do the carers have any concerns about their development, and are they reaching general milestones, which Maria will talk about afterwards. And then the usual drug history and allergies. Family history, in general, you want to ask if anyone else is ill at the moment, especially if the child has come in with like a viral kind of illness, you just ask if anyone else is ill. And then you want to ask about conditions that run in the family. And consanguinity is something, again, that feels a bit like, is this relevant? Sometimes it is, though. And, it's one of those things that, again, I would just practice asking all the questions because you never know. At our stage, we just want to be thorough. We just want to cover everything. I think they talk to you about how to ask this question. I think it's often, or I've heard it phrased kind of, are your parents related to each other in any other way besides being your parents or besides being married if they're married or whatever? Um, and you can just get some more information that way. And then social history, you want to clarify exactly who is at home. This can also be a good way to build rapport if, parents want to talk about their other kids. They say, oh, they've got two siblings. That's how old are they? Um, are they well? Are they in school? Things like that. Um, Ask about if the child is at school and just general are they having any issues, their general activities, especially if it's relevant. For example, like in asthma, you want to ask, are they active? Is their breathing getting in the way of them being active? And always ask, really important to ask if there's ever been any contact with social services. And then if, especially if they're an older child, um, consider a heads assessment. If you haven't done peds and you've never seen that before and you don't know what I'm talking about, it's essentially going into a longer kind of social aspect of what might be impacting someone's mental health. So you want to ask about home, eating, education, activities, drugs and alcohol, sex, kind of self-image and relationships. What was the other one? Safety, self-harm, suicidality, things like that. And safety in the general aspect. Is there anywhere they feel unsafe? Things like that. And include social media as well. So I'll move on to Maria.
Hi everyone. I've already introduced myself, but I'm Maria. I'm one of the final year medical students. Today, I'm going to start by tackling developmental milestones. So as you can see, these are all past med comments that I've taken. It's not a popular topic in pediatrics. A lot of it is rote learning. So I'll try to tackle these and give you mnemonics that will help you remember some important milestones. And at the end, I'll also talk through a mock OSCE station that came up in our year to do with this. So to give you an idea of how it's tested at UCL. But as you can see, the comment section for developmental milestones in PASMA is quite funny. So next slide, please. So first of all, what I would suggest, oh, perfect, thanks, is getting a piece of paper at home and just making a sheet of all the developmental milestones. And then maybe if you want to do that now, feel free and we can sort of fill it in as we go along. But the first question, I guess, is what are the 4 main developmental milestones groups that we assess? I know there's not that many students on the call now. You don't have to answer it because there's not that many of you. If you'd like to, please contribute. But if not, we could do this rhetorically as well. So if you just click on the next bit, please. Perfect. So the 4 areas that we're going to cover today is gross motor, fine motor / vision, speech / language, and then social. So there's 4 groups of milestones that children have to hit at certain ages, and we'll go through them. Next slide, please. So first of all, we're going to start with gross motor. So for gross motor, remember it's a reflection of how the nervous system matures and myelinates as you go along. Usually it'll follow in the same pattern. So obviously you won't be able to run before you sit, stand, and walk. So it goes quite logically. So top to toe, and then as a baby, you're flexed, but then as you become upright and start walking, you obviously start using your extensors a lot more. So that's the general theme so far. So if you just click on the next, please. So to give you an idea, so going from 3 to 12 months, so 3, 6, 9, 12, you can think of it as head, shoulders, knees, and toes. So first of all, 3 months, you have to hold your head upright. At 6 months, you have to sit unsupported. At 9 months, you start crawling. And then at 12 months, you start to walk or cruise by holding on to objects around you. So hopefully that's easy to remember. Brilliant. So next, at 18 months, you start to run. And then the 2, 3, 4 years, the way I remember it is you need 2 legs to jump. And then if you just click on the next one, perfect. So at 3, you need to be able to stand on 1 leg. So what I picture is an image of a kid like this who's standing with his 2 limbs out and on 1 leg. So that combined all together is 3 limbs. So that's the developmental milestone for 3 years. And then if you click on the next 2, and the next one too. Yeah, perfect. So, and then at 4 years old, you should be able to hop. And the way I remember that is that a kid that's hopping looks like the number 4. So hopefully that all makes sense. Next, please. So important milestones here. So we should you should seek to refer someone if they're not. Actually, I think if you click again, will come up. So there's lots of animations. So if they're not able to sit without support, you should refer them by 12 months. And if they're not able to walk by 18 months, that should be referred. And the way to remember that is you just add 6 months onto what the threshold usually is for them to achieve that milestone. So hopefully those 2 are the main ones. Okay, so if we go on to the next one. So fine motor and vision now. So for fine motor, first of all, they start by the palmar grasp at 6 months. So the way I remember that is you have an object in your hand, you have 5 fingers plus 1 object that you're holding on to. So that's your 6 months. And if you click on the next one, perfect. So main thing here is hand preference before 12 months is a red flag. And I guess I'm going to ask you why that is. And it was briefly mentioned on the previous slide as well on the table, but if there is any hand preference before 12 months, it's a sign of cerebral palsy, so it should be referred. So if you see a kid that is predominantly only using their right hand and sort of ignoring the left one, it could be a sign of cerebral palsy at that age. And then if you click on the next, and the next again, and so 6 months is our palmar grasp. And then at 9 months, we have our pincer grip. And pincer grip is you have a inferior and superior pincer grip. So it's basically holding an object between your first 2 sort of thumb and finger. So it kind of looks like a 9, if you think of it that way. So you achieve your inferior pincer grip by 9 months, and then your superior full pincer grip by 12 months. I don't know really what the difference is. I think if you remember that by 9 months, you achieve the pincer grip, that's fine. And then going on to drawings. So if you click again, so you might ask to your child that you're assessing, you might ask them to draw something on a piece of paper, and you start from the top in this case and work down to the bottom. So at the start, you'll ask them to just scribble anything. And if they can, that they should achieve that by 18 months. So it's a bit random. I don't really have a way of remembering it. I did write here that 8 is random, or kind of looks like a random number. I don't know if that's helpful. But then the others are bit more easier to figure out. So at 2 years, they're able to draw a line with 2 ends. So that's at 2 years. At 3 years, they're able to draw a circle. So a circle is 360 degrees. At 4 years, they're able to draw a square or a cross, both of which have sort of 4 sides or 4 components to it. And at 5 years, they're able to draw a triangle. Triangle requires more precision and sort of more accuracy to draw, and it's a bit more difficult, which is why that's achieved usually by 5 years old. Then if you click to the next one, and another way that you would assess fine motor and vision is by getting them to put together a block tower. And it's pretty simple to remember what their, I guess, how many blocks they need to achieve by a certain age by just taking their age and multiplying it by 3. And that should be the number of blocks they're able to stack onto each other. So that's something else that you might use in your fine motor exam as part of your developmental assessment. So moving on to the next one, speech and language. So very conveniently at about 6 weeks, if you click next, we have the newborn hearing program. So it occurs between 4 to 5, sometimes 6 weeks. And does anyone know how that is assessed? What sort of tool do we use to assess that? So we use the autoacoustics emission test, which basically you send a sound into a newborn's ear and you measure the sound waves reflecting back from the ear. And that's the wavelengths will change depending if the structures of the ear are present and normal. And you would expect a certain wavelength to hear back. So it doesn't require the infant to sit and sort of tap away every time they hear a sound. So that's more pure tone audiometry, which we use as an adult. If, however, the child has an abnormal newborn hearing test, then we do something called brainstem simulation test, I think, which is basically you get again a sound and you measure the sort of neural impulses to do with that, whether or not they can perceive that or not. So that's just stepping away from the developmental milestones, but kind of bringing everything together. So if you click next. So for speech, it's quite easy. So once again, if you click next, thanks. So we start by 3 months. Your child should be able to coo. So the way I remember that is coo has 3 letters. So it's pretty easy. They should be able to achieve that 3 months. Babble has 6 letters. So very conveniently, they start to babble at 6 months. And then at 9 months, they start to remember mommy, daddy. My friend had a mnemonic for this, which is basically, well, they spent 9 months, obviously, in their mom before they were being born. So you can remember that at 9 months, they should be able to say mommy and daddy. And then by the age of 1, they should be able to articulate one word, for example, pointing at objects and saying something. And then if you click next. So moving on from that, at 2 years, pretty easy. They should be able to say like 2-word sentences and point to themselves. So again, that's at 2 years. Everything has 2 in it. At 3, they should be able to answer the who, what questions and identify color. So C is the 3rd letter of the alphabet. I know this is a lot of mnemonics, but hopefully it helps to remember these. And at 4 years, they should be able to answer more complex questions like when, why, how, and ask them. And then in terms of speech, red flags. So if you click on next. Oh yeah, and just to say that by 3.5 years, they have about a vocab of 1,000 words, which considering they go from 6 months from monosyllables to 3.5 years of about 1,000 words, that's very rapid learning. But the red flags for speech are the following. So if at 6 weeks they're not responding to voice, once again, you might do more thorough auditory tests. At 12 months, they're not babbling. So again, that's your 6 months at which they're expected to babble plus an extra 6 months, which is your cutoff for referring. And at 18 months is your no spontaneous vocalization. So again, that's easy because you do your sort of 1 year plus 6 months. Again, that's your red flag territory for which you need to refer. At 2.5 years, they're unable to understand speech. That's a red flag. Considering at 3.5 years, they should have 1,000-word vocab. So hopefully that makes sense. And then finally, last one. So social milestones. So for these, if you click again, I found PASMED Commons really helpful. So there's lots of commons as you go through PASMED. If you get these slides, then you can refer to them as well. I've just collated a few of them, but you could remember it based on that way, but I'll teach you how I remember my social milestones. So if you click again, so by the age of 2, the kids do what they call parallel play, which is where they don't play with each other, but they play next to each other in their own kind of bubble. So you can remember that as the Roman letter 2 because the Roman number 2, sorry, because they parallel play with each other and it kind of looks like parallel tracks. Then next at 3, they start playing together. And the way I remember that is a bit of a stretch maybe, but 3, so a triangle has 3, not corners, angles to it. So I imagine a kid standing at each of those angles and kind of holding out a hand to the next door kid, I guess. So you can imagine 3 kids making a triangle and sort of playing with each other. So by 3 years, they should be able to approach each other and play with each other. And then at 4, they should be able to have fun with friends. So way more interactive. There's a group of them. They definitely are past that sharing toy stage. And then in terms of something that's asked is about the use of forks and spoons. So at 4, they should be able to use a fork and knife, both of which have F in it, so pretty easy to remember. And the way I remember a spoon is, click again, is basically half of 4. So by the age of 2, they should be able to use a spoon. So hopefully all of these are helpful. So if you go to the next slide. So this is a overview of all the developmental milestones we spoke about. Hopefully you can use this slide as reference. And then if you click again, these are some of the red flags that we spoke about. So actually, I forgot to say, children should be able to smile by 6 weeks. The way I remember that is after their initial assessment in hospital, they get seen by the GP at 6 to 8 weeks' time. So they should be smiling at their GP. If they don't, then they should be referred by 10 weeks. So hopefully, if you have these slides as reference, you could go through them. Next slide, please. The main thing I found really helpful in trying to remember these is the UCL sim session. So they go through a lot of their own mnemonics, a lot of which I've used, but also making sort of tables or charts of these things yourself, trying to maybe think of some stories. A lot of my friends in my year have stories for each age group, and the more ridiculous they are, the more likely you are to remember it. So that's really helpful. But if you go on the next slide, I also found PassMed questions really helpful because in PassMed, in the comment section, there's usually someone that breaks down everything. And if you find it useful, you can take a screenshot, put it into your notes and kind of use that as reference to build your own sort of columns, mnemonics, etc. So that's probably the best way of doing it, I think. But if you go on the next one, once again, you're 23 before you realize you can't answer these questions because they are relatively annoying and the pain of existence of studying pediatrics. But to piece some references together, so on the next slide, here's some resources which I found are really useful. So what I'm going to do is I'm going to put them in the chat as well for the people who are on the call now to use. But they're on the slide anyway. So the first resource, a guy's made flashcards with these milestone quizzes, and also as a side note for APGAR scores. So if you spend like 5 minutes doing that, it makes it much easier to answer questions from there on. There's also a few blogs where Regis have written out how to memorize these things, but also, and this is more pertinent to exams, the Paediatrics Society has developed some videos about developmental milestones. I think there's about 8 or 9. They're also available on YouTube and on their website. So in this case, I've put a link of their website. But if you go on it and as you're watching the video, you could write things down, what you see, try to guess the age of the kid. And then at the end, they'll be able to tell you all the sort of milestones that you should have seen in the video and what the approximate age of the child was. So it's probably the best way to learn in this case. So why is this all important? So if you go to the next slide. So these are previous OSCE stations from 5th year. So developmental milestones does come up as a station. It didn't come up for summative exams last year, but it has come up in the past. It's been heavily tested. So if you go on to the next slide. Thank you. So this was our mock OSCE PED station that came up literally 2 weeks ago. So if you're a final year and you haven't done your mock OSCE, maybe don't listen to the next minute. But basically what happened was they got you into a station. Each station is 10 minutes, as you know. You could play a video of 90 seconds up to a max of 2 times. You cannot stop the video once you start it. And they give you a worksheet to fill out. It's 2 pages and you have to list the following things. I think the one thing that really threw me off was you had to list age-appropriate skills. And when they marked you at the end, if you said things like, oh, the kid had a pincer grip or was pointing to things, for example, that's milestones of 9 months in 1 year, but actually the kid was like over 2 years, they wouldn't give you marks because it wasn't age-appropriate skills. So it would be like really subtle things like, for example, the child being able to complete a puzzle or being able to obey commands and stuff which were the points that they were looking for. And I think that threw me off the most because I didn't really know any age appropriate skills, if that makes sense. And then they asked you questions on how you might then assess this patient. Like, for example, in the video, she didn't have any tower blocks, so you might include that, or you couldn't see her using, say, like cutlery, so you might include that and stuff like that. So I think it was good to do it as a mock. Hopefully it doesn't come up in the summative, but just to give you an idea, if it does come up as an OSCE station, what to expect for this. So if you go on to the next slide, please. So here's our first SBA of today. So I'm just going to give you maybe half a minute to have a go, and then we can discuss what the correct answer is. And if anyone that is on the call here, if you want to put answers in the chat, feel free. You don't have to. Okay, so let's move on. I think that's enough time. So the main thing is, so actually feeding dolls was one of those milestones that I spoke about that came up in the mock, but doesn't really get mentioned. So that is a normal milestone of someone that's about 2 years old. She's able to walk upstairs. So remember, running, walking, that sort of stuff, so that all seems fine. She's able to scribble, unable to draw circles. Remember, circles 360, so that's at 3 years. She can say mama and dada without meaning, but no other recognizable words. So remember, saying mommy and daddy should be around 9 months, because remember, at 9, they spend 9 months sort of within their mum, and then they get born. So but no other recognizable words, that is the red flag. So actually, if you click on the next one, the correct answer is speech and language skills. So she's showing a delay there. And I think the important thing is, so gross motor, all fine, fine motor vision, we kind of discussed this. Socially, at 18 months, they start imitating their parents. And the way I remember that is at 18 years old, you think you're kind of independent and you don't need your parents anymore, and maybe you're too cool for that. So you can remember at 18 months that the kid starts imitating the parents in the world as he's around them. So hopefully that's all been useful. But yeah, that's it for developmental milestones.
Cool. So, I guess, I mean, before moving on, does anyone that's in the call have any questions so far? Just because I know it's a lot of information. No worries if not.
You can also send it as a chat or directly message me and I can answer too.
Yeah. If not, I'll just move on. So there's some RESP stuff, especially for SBAs, it's often like very similar things come up. So in this, we'll just talk about some of the main ones. Oh, be helpful with my slideshow. So immediately when you read the like vignette or whatever, the age is going to give you a lot of information about what you might expect. Obviously, these aren't like hard and fast rules, but they already start giving you an indication of what it might be. So we're going to talk about bronchiolitis, we're going to talk about croup, but we're going to talk about asthma, and we're going to talk about whooping cough. And asthma, you normally can't diagnose before 5. So that would be in the viral induced wheeze kind of section. And then immediately after birth, there can be some breathing issues, but we're not going to discuss them today. So just as general, good to know things to say you're looking for in like a RESP exam, for example, are things like tachypnea, dyspnea, Do they look like they're trying really hard to breathe, essentially? So do they look cyanosed at all? Are they able to speak in full sentences? Are they able to speak at all? And are they having like nasal flaring, but especially like grunting is like a big sign of respiratory distress. Apnea, obviously, if they're having periods where they're not breathing at all, is worrying. Tracheal tug, kind of look and see if the trachea, it almost looks like it's like pulling down when they're breathing. And then look for recessions, especially like intercostal recessions is talked about a lot, but also you can get suprasternal and subcostal. Just some good idea to think, like when you're initially thinking of someone having issues breathing, you want to use these signs to see, okay, like to what severity might it be. So we're going to start with bronchiolitis. Bronchiolitis is one of those things that comes up quite a lot. And important information to know, again, a very like SBA question, is that it's associated with the RSV virus. And age is less than 2, peak 3 to 6 months, but essentially if you're seeing a child less than a year, you really want to be thinking about bronchiolitis. And does anyone know, I mean, I don't know, does anyone know what you might look for symptoms wise for someone with bronchiolitis? Yeah, so you'll be looking for someone, it will be, they'll have like, they might have like a really dry cough. Often it will, they'll come in because of difficulty breathing. So if they look like they're breathing really fast, if they've got any of those recessions that we talked about. And when you listen to the chest, you will hear a wheeze, and crackles like throughout all over the lungs. They might have like a fever, but it will normally be below 39 degrees. I don't the specifics I don't think are that necessary. They might be there might be poor feeding, just like any other child that's unwell. And then if they're really young, they might show apnea. The importance of like the crackles being throughout the lungs is because if you only hear crackles in one area, you want to be thinking more about pneumonia, which is one of the differentials. So if you're hearing crackles in one area and it's not changing when they like a cough or anything, you want to be thinking more down the pneumonia route. And when I was in Paediatrics the other day, actually, the doctor I was with said not just look out for crackles, but really try and listen to air entry. And if they've got poor air entry in just one focal area, that might also be a sign more of a pneumonia. And that's just a good general tip. If you're listening to a child's chest, for example, in Pisliakova, there's lots of kids come in and, they would have been given their salbutamol and then they have like chest reviews. And when you're listening, I got really thrown off by, I was really focusing on if I could hear a wheeze, that I wasn't really paying attention to air entry. And then it turned out that there was quite a big difference between the air entry on one side and the other. So really good to try and keep a clear mind. Don't focus in on trying to hear one specific thing. And then if they're a bit older and they don't have any crackles and they've got some history of wheezing before, or a history of A to B, you might want to start thinking about, is this not bronchiolitis and is this viral onset wheeze or asthma? In terms of investigations, the main one is just pulse oximetry because you just want to make sure that their oxygen levels are okay. And actually, most children will be fine and they'll get better on their own. And you can just advise the parents to give paracetamol and NSAIDs and safety netting, looking out for signs of respiratory distress in particular. And there's a good website, I think it's called Healthier Together, and that has some good sites on like red flags. It's a good resource to talk about with parents, and it will have like green, amber, red signs and like who to contact about with each of them. But if they if they are showing signs of respiratory distress, you might want to think about not just sending them home with safety netting, obviously. So if they if their respirate's rate's really high, if their oxygen sats, they're not maintaining good sats. And if, because poor feeding is often associated with it, if they're looking dehydrated, you're going to want to bring them in. And for some kids, we have a lower threshold for wanting to bring them into hospital. If they're very young, if they were premature, if they've already got something that's going to make their breathing difficult, or they've already got something that puts them, I've forgotten my words, but already got a stressor on their health, so congenital heart disease, they're easily pushed over into becoming unwell. They've got like a low reserve. Then you would want to consider bringing them in, and they're more likely to be worse. And then obviously you want to advise parents to bring their parents straight to A&E if they have any apnea. If the opinion of a healthcare professional means a lot, if someone appears unwell to a healthcare professional, for example, like they go to the GP and the GP just thinks there's something not right, that is to be taken seriously, and they should go to A&E. And then obviously if they show really severe respiratory distress and any cyanosis, they should go to A&E. And then if they are brought in and they are admitted, it's going to be just supportive management. It's going to be oxygen therapy if they need that. And then if they're not feeding, you'll consider an NG tube and then potentially IV fluids. But with children, we always try and do the least invasive first. As soon as they're showing any sign that they might start feeding again, you want to get them doing that themselves. And then you want to discharge them if they're looking stable and they're maintaining good oxygen levels on room air for 4 hours. So that's bronchiolitis, just a quick stop tour. And on to the next common thing is croup. And croup is basically when you have swelling in your throat and it's affecting your breathing, most commonly caused by parainfluenza virus. And it peaks around the age of 2, like the instance. And you'll know they're talking about croup in like a question or in real life when they're mentioning stridor and when they're mentioning like a barking seal cough. And symptoms are often worse at night, but also when they're agitated. And with stridor, you're obviously concerned about how stable this airway is. And because it can be worse when they're agitated, examining the throat can make them more agitated and you're more scared about that airway blocking off. A doctor has told me that you can examine the throat in croup and just not in epiglottitis, but sometimes I know that I was taught not to do it in croup. Obviously, there are certain settings where it's safer to do so, but I think just bear that in mind with how the child is. And then for croup, there are basic different ways to think about it, but you want to categorize the severity. So if they've got just the cough, but they've got no signs that they're struggling to breathe, then it's mild. If they've started getting stridor, which is like the inspiratory noise, and they've got some recessions, but they're not too distressed by it, that would be moderate. And then once they start being like they're really distressed, they're really agitated, it's affecting their energy levels. They're obviously getting like much more, is having a much bigger impact on it, severe. And then any sign that the child is like getting really tired, the body's really struggling to cope with it, then obviously you're really worried about respiratory failure. So the management, they always get oral dexamethasone, and normally it will resolve quite quickly. And then the same goes about paracetamol, ibuprofen for dealing with fever or pain. And we always worry about children being dehydrated, so always encouraging fluid intake or getting them to continue breastfeeding or formula feeding. And safety net as always. Again, safety netting about any signs of respiratory distress. If they are on the scale of severity are moderate to severe, you want to think about admission. If they're less than 6 months, if they've got a lower threshold for admission or lower threshold for like more severe disease. And if you're not sure about the diagnosis, we'll talk about some differentials as well. So like I said, everyone gets dexamethasone, and then that is oral. Budesonide nebulizer would be like if they're really bad, like they can't take anything orally. And then give them some oxygen if they're not if they've not got good SATs. And then if it's severe, you can think about nebulized adrenaline. And then croup is a clinical diagnosis. But if there is some uncertainty, they might do an X-ray. And this is just a bit of a SBA thing. I don't know if you can see my my arrow. But there's the steeple sign here where you can see the swelling at the top of the throat kind of makes the trachea look like it's going to a point. And that's called steeple sign. That's more for SBAs. And so when you're thinking about differentials for croup, you want to think generally about differentials for stridor. So when you hear stridor, you're obviously concerned about the airway, and there are definitely some things you want to rule out, that being like anaphylaxis, or like a foreign body. So foreign body and anaphylaxis, you want to rule out straight away. And they can have like a peritonsillar abscess. So that would be maybe like a slower progression of disease. And obviously for that, and for the foreign body, I guess, like some examination of the throat will have to take place. But you worry about children with stridor that airway is just going to close off. So you want to try, and obviously unless it's an emergency, you want to examine that throat in a safer environment. And epiglottitis is one of the differentials, and that's the one where, they say really don't examine their throat. But epiglottitis, the child will look much more unwell than in croup. I mean, depending on the severity, but like epiglottitis is taught, you see it much less because it's caused by Haemophilus influenza B, which children are immunized against. So, but you will see signs like drooling, they're tripoding, they're really like trying to extend their neck to get that airway as open as possible. They look really unwell. And another differential for stridor is laryngomalacia. And that might be, I remember I was in a clinic and it was that a parent was concerned because at night the baby would have noisy breathing. But when she came into the clinic, the pediatrician could see straight away that this was a healthy child. The child generally looks fine, they're well. It's not a stridor that's really putting them at like big risk of their airway shutting. It's just when the larynx is a bit floppy, and so it can make a bit of noise, especially depending on the position. I'm sure there are exceptions where the laryngomalacia is like really severe and they need to go on to have further investigations and management. But my understanding is that generally the child will be okay and it goes away by itself. So one SBA that was on this presentation is, oh, let me get this out of the way because I can't read the top bit. So a 12-month-old baby girl presents to the GP with 10-day history of cough. She has bouts of coughing, which sometimes end in her vomiting. Her parents report she's had a runny nose for around 2 weeks, and her appetite seems to be decreased. The infant's immunization records are incomplete. So again, if you haven't done your peds and this is all new to you, don't worry. But there are some signs there indicating the diagnosis, and then it's just about learning the treatment. So the treatment would be azithromycin. So the vignette again is trying to get to whooping cough. So a longer history of a cough, these kind of attacks of coughing, which are quite severe, and they'll all happen at once. And then because of the pressure, children can get vomiting afterwards. And then children should be immunized against whooping cough. So if someone's immunization records are incomplete, you might think, has this child had the whooping cough vaccine? So it's caused by Bordetella pertussis. You can get it in infants, and then apparently there's a second peak at 14. I didn't know that. Some clinical features. Again, did I know all of these things before going into the exam last year? No. I mainly knew the paroxysmal phase, the coughing bursts, and then the whoop is from the actually like them trying to breathe in between the coughs. Again, worse at night and after feeding. This post-tussive or tussive, I don't know, vomiting. Again, from all that pressure of these attacks of coughing. And then if they're younger, they can have times of apnea or not breathing. So the clinical diagnosis, it's a clinical diagnosis, and you suspect it, again, if they've had a longer lasting cough, and if they've got some of these really characteristic features of it, and then ask if they've been in contact with anyone who's confirmed to have whooping cough in the previous 21 days. And then it is a diagnosis that then becomes confirmed. So you confirm it by like a swab or aspirate and or oral fluid testing or serological testing just to confirm it. Because it is a notifiable disease. So like I said, children normally get immunized in the 2, 3, and 4 months, and then when they start school. And because neonates are really vulnerable to whooping cough, pregnant women are offered the vaccine. I think it's from around like 20 weeks. So you can they can be admitted to hospital if they've got really they've got difficulty breathing, and again a lower threshold if they're younger. The treatment is with macrolides, so azithromycin is the typical answer. And this has actually changed. I think last time I checked on PassMed, it was still 21 days. But NICE guidelines have actually changed, and now it's only within 14 days of the onset of the cough can you start the antibiotics, unless you someone in your family is part of like a group 1 priority like group for like the community, getting the community healthy, something like that. Sorry, I really butchered that name. But that just means that if someone in your family is a vulnerable child or has contact with children that might be vulnerable to whooping cough, then you can start antibiotics within 21 days. And then school exclusion is if they are within the time to start antibiotics, then 48 hours after that, or 14 days from the symptom onset. Again, it's a notifiable disease. And then again, if there are people that are vulnerable, you might consider doing antibiotic prophylaxis. And then these can be some complications, mainly from like the coughing and the pressure changes. So next question is, a 10-year-old boy presents with difficulty breathing and widespread wheeze. He has a past medical history of asthma and you suspect an acute exacerbation. He is unable to speak in full sentences. His O2 sats are 90%, heart rate is 130, rest rate is 32, and peak flow is 40%. This is a classic SBA. It's also an easy SBA for them to put because it is just like these things are kind of categorized, and it's just there's very little up for debate on these. So if we look at rating the severity, I think almost everything in this vignette is counts under this severe category. So he had low SATs, his peak flow was 40%, his rest rate, I can't remember, but it was pretty high. He wasn't talking in full sentences, and his heart rate was pretty high as well. So yeah. Management, you would give them oxygen if they've got low SATs, or obviously if they're showing signs of life-threatening, that is obviously pointing towards like impending respiratory failure and really serious. And that needs to be escalated straight away. And every kid gets prednisolone, and then they will often get their salbutamol with an inhaler and a spacer. A lot of the safety netting will be if they're at home and they're taking 10 puffs and it's still not controlled, they should come in. And when they're giving the salbutamol, one thing I will say to be wary of is some of the terminology. So I remember, I think you get like a revision lecture or a prescribing lecture, and I think she describes burst therapy. And the burst therapy was like salbutamol and ipratropium, salbutamol, ipratropium. Whereas at the moment at North Mid, burst therapy in their like peds acute unit place was 30 puffs of salbutamol with the spacer. So just be careful with that. And when I asked them about it, she said that it can be different in different hospitals, but the salbutamol ipratropium nebulizers can be referred to as like back-to-back therapy as well. So you start off with just salbutamol, or if you need to give them something a bit stronger, you can do the back-to-back nebulizers. And then once you're seeing that things aren't getting better, or you need to escalate further, obviously you would get senior help by this point, definitely. You can consider adding magnesium sulfate, and then you've got to consider your IVs. So your IV salbutamol, but IV aminophylline and mag sulfate. And just watch out with giving loads and loads and loads of salbutamol can make them quite tachycardic as well. So that will also sometimes direct you to maybe having to use something else. So someone comes in and they have an exacerbation of asthma. They spent their time in the PAU doing all their burst therapies, taking their inhalers, getting regular chest reviews. And then you can think about discharge when they're stable on 3 to 4 hourly inhaled bronchodilators, and their peak flows back to normal, kind of enough, and they're maintaining their oxygen saturations. But when you're discharging someone from hospital or from like the acute unit or anything like that, there's a lot you have to think about. So you have to think about, why did this happen? You have to check their inhaler technique. If they have an inhaler and it just wasn't being effective, you really need to check that. And educating them, you have to really go through, has this happened before? Kind of identify any triggers. things like that. Well, I think we'll talk about important things to discuss in like history of asthma and like follow up. But yeah, a real focus on inhaler technique and patient education, and again, just go through like safety netting. Um, you have to prescribe the prednisolone. They have to have a follow-up in GP within 48 hours if they weren't admitted, or 2 working days if they were admitted and then discharged. And then they will almost always get followed up by a specialist, depending on like the severity and how often it's happened. Um, I'm not sure exactly how often they will be seen by the specialist. I think it depends on that. But just know that that is going to happen. And then you want to ensure that they've got a good asthma care plan. So this is one version of what an asthma care plan can look like. There are some different versions, but essentially being like, this is my normal inhaler, this is how I take it. I also take this. If my asthma is like this, then I know I have to do this. And then it has some safety netting of that as well. So really important to go through that as well. So what might you discuss when taking an asthma history or doing a follow-up? If you're doing an asthma history or follow-up, they've come in, it's very likely that it's happened before. This isn't the first time they've come in with a wheeze. So you really want to establish timelines. You really want to establish how often has this happened before? At home, do they ever struggle with their breathing? When they're doing activities, are they managing to run around? Is their breathing getting in the way of anything? Have they previously been given an inhaler? Even if they don't have a diagnosis of asthma, if they're under 5, they might still have been given an inhaler because of previous wheezy episodes. So really ask them about that. Often you'll ask them and then they'll be like, we got given an inhaler, we used it that one time, and then that's it. So you want to ask, of course, the like colors of the inhalers, which inhaler are they using when? Make sure if they have a brown inhaler, the steroids, that they are taking them every day. You go through all like inhaler technique as one of your DOPs. Useful to do that in GP, I found. But you could also do that here if there's like an asthma nurse or asthma clinic. And yeah, really kind of get into like the nitty-gritty of exactly what are they doing with these inhalers and what can be made better. And you also want to ask about history of atopy. Do they ever get any hay fever? Do they have any allergies? Ask, do they have any pets at home? Does anyone at home smoke? All these things that you really want to check that you've kind of discussed and gone over, that might be one, putting them at risk, but two, kind of can anything be changed to get them back in better control? So then I'll move on to Maria.
Oh, thanks for that, Giulia. That was a really good rundown respiratory conditions. So I'm kind of continuing on the same theme of viral rashes. So next slide, please. Perfect. So we're going to start with an SBA. So I'm going to give you half a minute to read and try to answer, and then I'll go through it.
Sorry.
That's fine. Okay, we'll go through it anyway now. Perfect. Well done. Okay, so major clues here are rash that started from behind the ears, and we're going to talk about that, and the child having an incomplete vaccination history. So when you're doing peds, apart from developmental milestones, the other bane of your assistance will be immunization schedule. And knowing which vaccines are given when is important, but also in general, knowing which viruses we don't have vaccines for, or I guess bacteria too, is very important, because if a child doesn't have a complete vaccination history, it gives you clues as to what they may have, and then vice versa, obviously, if they've been fully vaccinated. So major clue here is a rash that starts from behind the ears. That is very typical of measles. And if you click again, You see this very characteristic, what we call Koplik spots. There's these white spots inside their mouth that you'd see on examination. That is pathognomonic for measles. And if you click again, um, these are the main complications of measles. The reason why the SBA is set on measles is because if you have to discuss the MMR vaccine as part of your OSCE, then the measles virus is probably the main one you need to know about and be able to explain to parents the complications of. So if you do remember any complications of any virus infections, of which we vaccinate, the measles is probably the main one you should probably hone in for. The easy thing to remember, though, if you know that measles starts behind the ears, and I don't know if you saw, but when it was an option in the answers, I wrote, instead of writing measles, I wrote measles. So you can remember measles as having the word ear inside of it, if that makes sense. So you can remember that the rash starts behind the ears, and then the main complication of measles is an otitis media reaction, so middle ear reaction. So those kind of go hand in hand, are quite easy to remember. The other ones you kind of need to work down/up. So measles, the next most common thing is pneumonia infections, but you can also work up and get meningitis, encephalitis, as well as subacute sclerosing panencephalitis, very rare, but it's a complication of measles where children can start developing symptoms like after 7 to 10 years post-infection of all sorts of sort of space-occupied lesion-like symptoms. And it was actually due to a measles infection. So the reason why I wanted to talk about complications of measles is because that's probably the main one you're going to have to talk about during OSCEs when discussing the MMR. Next slide, please. So this is a slide. I didn't make it. This is from the previous people who made these slides. But this is a table of all the childhood rashes they need to know about. So as well as the well, measles is on here too, but rubella. So remember, rubella, a congenital rubella infection will also cause a triad. I don't know if you know what the triad is. So you'll have cardiac abnormalities. You'd also have cataracts and sensory neural a hearing loss. So those are the triads of a congenital rubella infection. But as a child, if you're infected with rubella, the main thing that stands out are the lymph nodes. So you'd have like really massive lymph node involvement, and that was quite typical of a rubella infection. Then measles, we spoke about measles already. So the Koplik spots, which are pathognomonic in the throat. And you'd also have a rash that starts behind the ear that you already know and are able to discuss all the complications of measles too. Chickenpox is a vesicular rash that becomes widespread. And the main thing is we're going to talk about school exclusion criteria, and I'm going to give you some mnemonics to remember these as well. And then Roseola infantum, so also known as HHV6 infections. It's a virus. The main thing about this is that the rash appears after improvement of the infection, and I'll give you a mnemonic about that too. Finally, we have retrovirus B19 infection, also known as slapped cheek syndrome. You probably covered this in 4th year. But the main complication of this is aplastic anemia, and something to look out for as well. So in terms of mnemonics, so if you click 3 times, they should come up. Thank you. So for chickenpox, school exclusion criteria, so I remember that chickenpox, I mean, it's a bit gross, but goes crusty. So all the lesions have to crust over before the child is able to return back to school. For HHV6 infection, so it's kind of in the name. So Roseola infantum starts with an RI, so you get the rash after improvement of symptoms. That's how I remember that. That's very classic SBA question. And then in terms of the school exclusion criteria for scarlet fever versus whooping cough. So scarlet fever, I remember, is S, so it comes before W in the alphabet. So children are excluded for 24 hours after commencing antibiotics, whereas whooping cough comes after S in the alphabet. So that's 48 hours after commencing antibiotics. And as Giulia already mentioned, that's azithromycin or clarithromycin within 21 days. So once again, scarlet fever is 24 hours after antibiotic commencement, and whooping cough is 48 hours after antibiotic commencement, just based on that alphabetical mnemonic alone. But for some reason, I grouped those two together in my mind. So hopefully that's helpful. Feel free to refer to the table in your spare time.
Nice. That was a nice quick overview on some of the most important rashes. So fluids. Fluids is one of those things where it can be really formulaic, but also if you start questioning things, you just kind of go down a hole of where the answer is always like, oh, it depends. So to not get completely overwhelmed, I would stick to basics. I think basics is what they expect from us. So I can move on. Yeah. So first of all, resuscitation fluids. You can see online, some websites will say like 20 mil per kg, but I think now it's pretty standard to just give 10 mil per kg, and then if another one is needed, you go on to give that. But you don't want to like overload them. You don't want to give them too much too quickly. So 10 mil per kg of standard NaCl. And if the child is in shock, just like with adults, if they're in shock, you don't need to subtract the resuscitation fluids from the maintenance fluids. There are cases such as in DKA, where they will give faster fluids to a child. It'll be kind of like a slow bolus, and then they would subtract that from the rehydration fluids because the child wasn't shocked. But again, that's more like niche stuff. If we're doing basics, 10 mil per kg, standard sodium chloride, and don't subtract it. Don't worry about that. In terms of maintenance, this is just one of those things that you have to learn. You have to just learn that the first 10 kg do 100 mil per kilogram per day. Second 10, you do 50 mil per kg per day. And then the rest is 20 for every kg after that. And then when you're prescribing it, again, I think someone goes through it in like a revision, in like a prescribing lecture. But in the box, you would do it with a 500 ml bag normally. And you would do 0.9% saline plus 5% dextrose is the fluid type. You'd work out how much you're going to give in the day, divide it by 24, and where it says duration, cross out duration, you put rate, and you just put your rate. So you just prescribe the first bag with your rate, and that's it. If it's maintenance only, you often, if they are fully reliant on IV fluids for maintenance, then you would probably add potassium. I believe I saw like a Whittington thing say 20 millimoles per liter, and that matches up with what the prescribing lecture says. I think they do 10 millimoles of potassium in their 500 bag. And then you really want to add potassium if they're having losses. Again, that's a thing that in DKA they need lots of potassium. But generally you allow like your usernees to guide how you're going to adjust things. And just a point to know that in hyponatremia, this is for replacement fluids that they're talking about. Sorry, I didn't change what slide it was on. But when you're replacing fluids, which we'll talk about in a second, you replace them slowly, but I repeat that on the next slide. So just to say the main things again, you work out your total based on their weight in kilograms, you divide that by 24, you put in your rate instead of a duration, and you write 0.9% saline plus 5% dextrose, and then you consider maybe 10 millimoles of potassium. But the potassium is one of those things that obviously you need to allow usernees to guide it. This is an example. I think I will let you guys go through this in your own time. At the end of the day, it is basic maths. It's just being aware of the formula. So if they're 27, once they're at 20, you know that it's 1.5 liters. And then you can just add on your 20 mil for all the next ones. But obviously, if they're smaller, you have to kind of think back. So this would be the calculations. That would be your total. You would divide it by 24, and that's what you would put in the duration box, because you'd cross out duration, you would write rate. Right. So again, that's to go through in your own time. And if you've got a child that's dehydrated, and we'll talk about how you're going to know that they're dehydrated, but let's just go, they are dehydrated, what are we going to do? To calculate how much they need to be replaced, you need to think their weight times their percentage dehydration times 10. And now percentage dehydration, what can that be? You start seeing signs of dehydration, like physical signs, at around 5%. So, and then it kind of progresses to where they're severely dehydrated, potentially going into shock around 10%. So it's kind of on a scale of well to shocked. It'd be less than 5%. They might be mildly dehydrated, but they're not showing any clinical signs of dehydration. Mild dehydration, you can estimate around 5%, and then it kind of moves up to severe would be 10. And the most accurate way of doing this is just doing what proportion of their weight have they lost, and you assume that that's water. That would be more ideal, but maybe we don't have up-to-date weights for everyone. And so there has to be a way of estimating it. Before this on the slide, they had this table and it said like mild was 5%, moderate was 10%, and severe was 15%. But I could not find that anywhere else. And I learned that 10% was kind of like your severe leading into shock. And if it's mild dehydration with some signs, it would be around 5%. I think if it was an SBA or a prescribing station, then they'd have to be pretty clear on the percentage dehydration, like they'd either give it to you or make it really obvious. But my prediction would be that they'd give it to you because NICE guidelines don't give such clear-cut 5-10%. So when you have to replace these fluids, you just add that onto the maintenance, divide it by 24. That's your new rate that you're going to give the fluids at. If they're hyponatremic, on the previous slide when it said hyponatremia replace slowly, this is what they mean. Instead of doing 24 hours, you would do 48 hours just for your replacement bit. So you'd get your normal maintenance plus half of this calculated replacement over 24, and then you do the next half the next day. In the corner, I've put in the BSPD guidelines for DKA. DKA has its own kind of like fluid management of dehydration. Worth having a look at. I don't get overwhelmed by the nitty-gritty detail because again, like this is something it's very like guidelines based, and in a real life scenario, you can be like, I would check the guidelines. But it's useful. They talk about giving boluses, giving the slow bolus to people that aren't shocked but dehydrated. I believe they don't do the like normal saline plus dextrose all in one. I think they do just normal saline for their rehydration with lots of potassium. But worth having a look at that because that's kind of a different scenario where quite a specific fluid regime would have to be upheld. But if we're back to our basics, you just got to remember this formula and remember that you add it onto your maintenance and do it as a rate over the 24 hours. So assessing fluid status, again, like I said, NICE doesn't give very clear-cut, mild is 5%, severe is 10%. But what they do is they say, is the child well? Are they showing signs of clinical dehydration or are they shocked? So that is this. A lot of words, don't be overwhelmed. The left column is basically they're fine. The middle column would be they're showing signs of dehydration. So you'd think at least they'd be around 5%. So decrease urine input. If they're still warm, but they're obviously showing some signs that they're dry, they've got reduced skin turgor, their blood pressure is still being maintained, but they're just showing signs of dehydration, they're a bit dry. And in this, there are some red flags. So in this, red flags would be if they've got a change in their alertness, if they've just repeated that, I don't know why. If they have sunken eyes, if they're tachycardic, if they've got a high rest rate, if their skin turgor is reduced, then you might want to be thinking this is a child that could potentially go into shock. And then clinical shock would be pale, mottled, they're cold, then conscious levels low. They have the tachycardia, they have the high rest rate. Cap refill is prolonged. So when you're assessing a child, things you really want to check: cap refill, check do their hands feel warm? You ask them about wet nappies, or if they've got decreased urine output. You take their obs, and you use all of this information to guide how you're going to deal with it. So these are from the gastroenteritis guidelines. Gastroenteritis does come up, it's just a common precipitant of dehydration. And if you spend any time in Peds A&E, you probably will see someone with gastroenteritis or some kind of bug. And with those children, you just want to make sure that they're hydrated. So often you'll see children being given, or their parents or carers being given a syringe, and they're told give 5 mils of fluid every 5 minutes or something like that. Essentially to test if the child can tolerate fluids and stay hydrated before you send them home. So that would be, maybe they're well, or maybe they're just saying that, urine output's decreased, and they're looking slightly dry, that you would want to do that. If they are completely well and they just come in and because they've vomited like 10 times, often they will just screen for any signs of dehydration and be sent home with safety netting advice about dehydration. The next step up would be, at least for under fives, I know that there's like oral rehydration solution. I think the NICE guidelines are 50 ml per kilogram over 4 hours. I wouldn't get too bogged down about learning that specifically. I think knowing that oral rehydration fluids are a good thing to do in like the A&E scenario where you want to check, can this child tolerate these enough fluids to be well at home? And then if they're starting to show signs of like some red flags, and they're not tolerating these fluids, either the syringe of like 5 ml every 5 minutes, which is also referred to as like a fluid challenge, which isn't a bolus, it's a fluid challenge, like an oral fluid challenge of can they tolerate little and often, which is often the best way to get children to stay hydrated. If they're like throwing everything back up and it's not working, the next least invasive might be an NG tube, again, depending on the age. And then if they're deteriorating despite trying the oral rehydration fluids and they're showing signs of shock, or they come in and they are shocked because they're so dehydrated, then that's when you'd go for your IV access and your fluid bolus and your IV fluids. So this is, again, working through the rehydration thing. So we already worked out this 27 kg child's maintenance. So now you just want to do the 10% times 27 times 10 would be what you're adding onto that. So that would be our maintenance, our replacement. And then if you think about the replacement at 10% dehydration, that is a lot of extra fluid you're having to give to a child. So again, if you think a good way of remembering that 10% is like pretty bad, is think about how much fluids that would require. And then this is a question that was left in it, that I left from the original slides. Again, kind of going over what we spoke about dehydration and what you do depending on how dehydrated they are. So 1-year-old has diarrhea past 12 hours. He vomited at the beginning. Importantly, he's not vomiting now. He's not passed urine for the past 6 hours. He's thirsty, he's restless, his eyes are sunken, his mucous membranes are dry, and his skin turgor has decreased pulse is 160, and cap refill time is 2 seconds. For the sake of time, and because, like I said, it doesn't fit nicely into mild, moderate, severe, we can see from the previous table that he's showing some red flags of that he's obviously clinically dehydrated, but showing some red flags as well. But you wouldn't jump straight into IV saline. You always want to start with the least invasive option, and you want to see if he can respond to oral rehydration solution. So that is what you would do. And this is where they talk about the 50 ml per kilogram over 4 hours. And then you would escalate if necessary. So on to Maria.
Okay, so this is my last section of today. I'm going to cover neonatal jaundice. I had really good teaching in Luton from a neonatologist on jaundice. So I've just kind of replicated his my teaching notes into slides. So hopefully you'd find it helpful. So next, please. Thank you. So let's think about jaundice first. So what is jaundice? So let's just go straight into it. So jaundice occurs due to red blood cell breakdown, where you get the release of bilirubin. And the reason why neonates are more likely to be jaundiced is because they have more hemoglobin compared to adults, because remember, they float around in a pretty much hypoxic environment until they're born. And also their maternal red blood cells, which are within their circulation, are being broken down within the first few days as well. So in general, neonates are more likely to be jaundiced. And I wrote the liver here, and we're going to speak about that in a second. So where do we detect neonatal jaundice? So if you were to examine a baby, first of all, you look at if it's not evident by the skin, and sometimes it's really hard to be detected. We'll look in the sclera, so in the whites of the eyes, they might look yellow. You might look in the gums, as soon as in this picture here, might also appear a bit yellowish. And you might also try blanching the skin and seeing if that blanched skin is yellow. However, in any case, if you have clinical suspicion or if you do see jaundice, it needs to be measured, and we're going to speak about how it's measured later on. So going back to the liver now. So the liver does many things, but one of the functions of the liver is to conjugate your bilirubin. So we have circulating unconjugated bilirubin from red blood cell breakdown, which the liver then conjugates and is therefore a soluble, excretable form that can then be excreted by the kidneys in the form of urine. So importantly, in neonates though, so if you click again, this process starts happening around 3 to 5 days, because the liver isn't actually switched on. So remember, there's lots of blood shunting away from the liver as well. So it takes a few days for the liver to kick in. So keep all of that in mind when we talk about jaundice. So going to the next slide now. So if we think about it as a timeline from birth, so if you kind of triple click now, there's 3 different types of jaundice and when we might see jaundice. And jaundice is not concerning if it's at certain points of time. So if we see jaundice within the first 24, 48 hours after birth, that is always pathological, and that is always concerning and needs to be acted on. If we see jaundice from about 2 to 14 days, that is not so serious. Because remember, the liver starts to kick in. So it might be just that the liver is taking a little bit longer and it's starting to conjugate all that raised bilirubin level. And therefore, and that's due to, you know, all those factors that we spoke about, just neonates having more red blood cells and the maternal red blood cell breakdown, etc. So that is all your physiological jaundice, which is usually thought as normal. Remember, it still needs to be measured and it still needs to be not as much as investigated, but levels need to be kept an eye on until it reaches 2 weeks. These patients are still followed up, even if it's physiological jaundice. And then if there's jaundice that goes past 2 weeks, then it again becomes pathological. Don't confuse yourself with neonatal hypoglycemia. And we're going to talk a little bit about that as well, because it has like a similar timeline, except it's pathological and physiological at different points. So what I found helpful was drawing two timelines, one for jaundice and one for hypoglycemia, to kind of compartmentalize it in my head. So if you click now, so remember, physiological jaundice is normal from 2 to 14 days, and it's because of all the stuff that we spoke about, as well as breastfeeding can also raise your bilirubin levels too. But red flags, so if you click again, pathological jaundice either being in the first 2 days or after 2 weeks, so easy to remember because 2 days or 2 weeks is pathological. There's many risk factors, which prematurity, low birth weight, history, etc., all come into play. So let's break jaundice down. So if you click on the next slide, this is a table of causes of jaundice. I personally am not a fan of tables. This is from someone who has made these slides previously. So I've kind of broken it down into how I was taught in this seminar, which I hope is probably more useful. So if you click on the next slide, so let's talk about the first 24 hours. So how is our jaundice within the first 24 hours different from the one that starts from 2 weeks on? So remember, in your first 24 hours, the main contributing factor to jaundice is increased red blood cell breakdown. And that could be due to a number of factors. So exactly right. So sepsis being the first one. So if you have septicemia, you'll have an increased red blood cell breakdown. Incompatibility, so either rhesus incompatibility disease, so remember your HDN, hemolytic disease of the newborn, or it could be ABO group incompatibility as well. So it could be your major blood types as well. Then going into point number 3, it could also be to red cell abnormalities. So think about anything congenital that can increase your red blood cell breakdown. So be it spherocytosis or G6PD. So if you click now, investigations for these are reflected of the causes. So red blood cell abnormalities, we want to get a blood film to see what the shapes of the red blood cells are. For incompatibility disease, we want to do a Coombs test. So that's your antibody sort of antigen on your blood cell test. So trying to see what blood type the baby is, what blood type the mom is there any incompatibility there? And then finally, for sepsis, if you click again, going to the blood films. So on your left, you have your spherocytosis. So that's a blood film of some spherocytes. And on the right, you have your G6PD bite cells. So remember, they kind of look like almost like Pac-Man or like something spitting off of them. The way I remember that is, you probably remember from first year, like the rogue fact of G6PD is to do with these fava beans. So consuming these fava beans can cause an attack. And so I think of like biting a bean off, and that's exactly what the red blood cell looks like. So that's a bite cell, which is seen in G6PD blood films. So if you click through that, fine. And then sepsis. So for neonatal sepsis, you want to do a full septic screen of the neonate, as well as a torch screen. So remember your toxoplasma, others, rubella, CMV, and HIV, and also syphilis. Sorry, Hep B, I think, not HIV. Hep B and syphilis. So you'd want to screen for all of those in case that's what's giving you the sepsis, as well as your Group B strep. Fine. So, and we'll remember in the first 24 hours, if I were to ask you, what kind of bilirubin will you see? Will you see conjugated or unconjugated bilirubin? So remember, this is mainly unconjugated bilirubin because your liver is still not in that process of being able to conjugate this bilirubin. So it's still unconjugated bilirubin jaundice in the first 24 hours because the liver still hasn't kicked in. It still hasn't been those 3 to 5 days. So take home message, if you click again, is it's always pathological in the first 24 hours. So don't confuse it with hypoglycemia, where transient hypoglycemia within the first 24 hours is normal. Jaundice is always pathological in the first 2 days. Okay, so hopefully that makes sense. Now let's talk about what happens after 2 weeks. So this is a slightly different picture now. So our liver is fully up and running, so it's able to conjugate bilirubin, right? So in order for bilirubin to then be excreted in the kidneys. So if we have a neonate that is jaundiced at week 2, what we do is we do a blood test. And what we look for is either a raised conjugated or unconjugated bilirubin levels. So if you click now. So first of all, we're going to talk about the unconjugated bilirubin. So why would you have high levels of unconjugated bilirubin at week 2? So if you click again, That's due to your liver maybe not excreting it as well. So it's due to a liver issue, right? Because the whole idea of the liver at week 2 is to be able to conjugate that, to be able to process that bilirubin. So if you have high levels of unconjugated bilirubin, that gives you an idea that's something to do with the liver itself. So it's an intrahepatic issue. So if you click again, the main condition that you need to know that comes up in exams is this Kernicterus. Sorry, I don't know how to pronounce it though. And that is when your unconjugated bilirubin crosses the blood-brain barrier, which it is able to do so and causes changes within the brain. So it's neurotoxic and it can induce a whole range of symptoms from irritability all the way to coma and death. And is also a cause of cerebral palsy after birth. So that's why we want to, even if it's physiological jaundice within those 2 weeks, we still need to monitor these levels for unconjugated bilirubin, sorry, in order for this condition not to happen. So that's why neonates still need to be monitored. So hopefully that makes sense. Then we're going to talk about the conjugated bilirubin now. So conjugated bilirubin, if there's high levels of conjugated bilirubin, so if you click again, that is suggestive of a post-hepatic issue. So your liver is able to deal with conjugation. So it's no longer to do with the liver, it's to do with something else that's going on. So if you click again, the main disease you need to know here, or main syndrome, I guess, is after week 2, if you have high levels of conjugated bilirubin, most likely the cause is biliary atresia. And what happens here is that although your bile is secreted, what happens is you have a blockage either from an infection, so CMV, or a stricture, something happens where you basically no longer can excrete bile, and you have all of that build-up of conjugated bilirubin as well. So you get the classic dark urine, pale stools. So you see that in gallbladder diseases like cholangitis. So the investigation here would be a liver scan because you're trying to see that stricture and to see if bile is being excreted. You might even use a nuclear dye. So in this case, to see if it goes through the biliary tree or not. The only management here is surgical. So it's with a procedure called this Kasai procedure. So these are the 2 main issues you need to know about after day 14 if the neonate is still jaundiced. So hopefully that makes sense. So next slide. So how do we investigate these? So quite simple, actually. So visual assessment, which we spoke about earlier. If suspected or detected, we must measure it. There's only 2 ways of measuring jaundice at the moment. So it's usually kind of like through a camera where you put it to the skin and it's able to measure whether or not the skin appears jaundiced and able to quantify that. And it is validated for non-Caucasian babies as well, and it works quite well. And also we can use serum bilirubin measurements, and also that will give us an idea of our conjugated versus unconjugated levels too, if we're trying to think about causes. So if we go on to the next one. So after we measure our serum bilirubin, the main thing here is that each trust will have a slightly different graph. But the idea is that you would plot the levels of bilirubin you'd see in the serum against a graph like this. And depending on the threshold and where that serum level is, you would give different types of treatment for it. Importantly, this is adjusted for gestational age. So if the neonate is born prematurely, then that'll be adjusted as well. A general threshold is 250 micromoles. In that case, you would start managing the jaundice in this infant. But depending on where it crosses, you would initiate different types of management, depending on the severity. So we're going to talk about that now. So management, is, as we said, is dependent on the levels that you measure. So the first thing that you might do is phototherapy. So the idea, this is the mainstay treatment of jaundice. And the idea is you want to turn your unconjugated bilirubin level, and via phototherapy, it becomes water soluble without conjugation from the liver. So when it becomes water soluble, it's able to be excreted by the kidneys in urine, and therefore the levels will go down in your serum. So that's the mainstay treatment. If it's more severe and if there's really high levels, then you might do the second thing, which is exchange therapy. So it's the removal of bilirubin from the blood by exchanging blood. So it's kind of like an exchange transfusion. Very interestingly, though, does anyone know how many mils per kilogram of blood do neonates have? And if you click again, it will reveal the answer. But generally, neonates have about 80 mils per kilogram. So if you think about your premature neonates too, so they might even be half a kilogram in some NICU facilities. So that's only 40 mils of blood around the whole body, which is pretty amazing. So we do an exchange transfusion to make sure that they still have enough blood because they don't have that much to begin with. But the whole idea is you remove bilirubin from there. And then finally, I think which you can add on to this at the end is if there are any incompatibility diseases, be it rhesus or ABO incompatibilities, remember that first 24-hour pathological jaundice, you could give some IV immunoglobulin. And the idea is that if there's any antibodies that are cross-reacting with the blood causing this incompatibility disease, they'll be sort of diluted by this overwhelming IVIG that you're putting into the bloodstream and hopefully sort of diluting that incompatibility effect. So hopefully that makes sense. So an SBA on this on the next slide. So you're performing a newborn baby check on a 5-year-old infant. During the assessment, you notice jaundice and yellow pigmentation of the skin. So what is the most appropriate course of action? So I'll give 10 seconds. Actually, we probably don't have 10 seconds in the interest of time. So next slide, perfect. So here we have a presentation of pathological jaundice in the first 24 hours. So remember, 24 hours is always pathological, either 2 days or 2 days or 2 weeks, sorry. So within 2 days, the most likely causes are either sepsis, first of all, second of all, incompatibility disease, or third of all, I can't remember what the third one was now. Red cell abnormalities, sorry. So in this case, we want to do a blood film to see for any red cell abnormalities here. So you can see schistocytes on the left and Heinz bodies, which indicate hemolysis. So hopefully that all makes sense.
Cool. We're almost done. It's a lot in one session, so if your brain is pretty fried, don't worry, mine too. Quick note on BLS is just like some main differences that we need to keep in mind is for infants, neck position. You don't want to do head tilt chin lift because that will kind of like cut off the airway again. You want to keep their neck really neutral. Sometimes it's called like sniffing the air position. And then for children, you can do head tilt chin lift. But sometimes you have to do it to a slightly lesser extent. But you can normally do the same technique. Compression, the rate is the same as with adults. And with the actual technique of compressions, if you've got an infant, you basically want to hold them in your hands, encircle, have their chest within your hands, and then your thumbs are at the front, and then you use your 2 thumbs to do the compressions. Same like a third of the way through the chest. And with the children, depending on their size and your size, you might use 1 hand. If you need to use 2, use 2. And then the main difference is that it's most likely from a respiratory problem. So you always start with your 5 rescue breaths. And then the proportion, again, for that same reason, the proportion of compressions to breaths is different. So you do 15 chest compressions to 2 breaths. And then a note on like foreign body obstruction, which is always good to know. You do your same like 5 back blows and 5 abdominal thrusts. Um, for infants, the thrusts are chest thrusts, and it's just the same technique as your compressions, the encircling. You can use your two thumbs, going that trying to get deep enough into the chest, and you just do it slightly slower with slightly more intention all the time when you're doing it. If you're doing the kind of like back blows, or you're looking or you're doing the abdominal thrusts or chest thrusts, always look for if the obstruction has come out. You don't want to be continuing to do it when the thing is already flown out of their mouth. These are just some basic algorithms to go through. And this is like a QR code for those algorithms to make part of it, but they also go through like asthma and everything. It's really helpful. And they included neonatal BLS in this presentation. I don't personally think it's really that important for us to know at our level. But this is kind of like a summarized version, and the QR code is the more extensive version. I will let you guys go through that in your own time. But yeah, I think it's good to know, maybe not like the essential. I don't remember this being in our like sim session when we went through pediatric BLS, but I might be wrong, you never know. Um, and then I just made a note on the next one, something you do tend to need to know, especially for SBAs, is the APGAR score. I know that Maria mentioned it earlier in one of the resources. So you just look at their appearance, their pulse, their grimacing, their activity and their respiration at 1 minute and 5 minutes. And then only if they have a low score and if you need to reassess, you go to 10 minutes. It's quite normal for them to not be 10 out of 10 when they are first born. But just good to know as a way of seeing if they're well or not when they come out. And I think we'll call it a day there. It's been a lot. We've gone through a lot of stuff. I know there's like one extra person in this chat at the moment. If you want to do a feedback, would be much appreciated. But yeah, it just helps us. And then if there's if there's a way that these can be improved, I know it's a lot of information. I think peds is a really big topic, and it's trying to balance saying all the important information and also having these slides be a good place of reference. But yeah, any questions at all?
I guess one thing to say is if you do watch it as a recording, please fill out the feedback as well. It would be of big help to us. But thank you for spending your Thursday evening with us.
Cool. Oh, just looking at them.
Brilliant. Thanks for coming.
Nice. Thank you for coming.
I'll stop the recording
Yeah.
now.